And a diagnostic setup showed that we have spaces for the missing laterals. So the arch length deficiency is almost 0, and the profile calls for non-extraction. So the decision was to open the space. Now, when I say open the space, I want to insist on the fact that there is no one space. We're talking about 3 spaces when we are going to consider implants. The crown space, which is dictated by aesthetics and occlusion, as we are going to see. And there is also the space at the crestal bone level that depends on the size of the implant, knowing that we need on the average 1.5 millimeter on each side between the implant and the adjacent root for the papilla and to avoid bone necrosis. And of course, the root space for the insertion of the implant. So this is root parallelism when I talk about root space. Now, how do we check root parallelism? This is an interesting study that looked at panoramics versus combing computed tomography, which is very precise as far as root parallelism. And it showed that panoramic is not a good X-ray for root parallelism. And root contacts were overestimated when evaluated by panoramic. This is another study. Also, I give you the conclusion that panoramic radiograph cannot be used as a reliable guide to a certain tooth angulation. Now, CBCTs, which is the most accurate guide or X-ray, is not justified for the routine control of root contact, especially that sometimes you have to monitor during treatment. So it's not justified to take CBCTs regularly on a regular basis. Instead, what is a good and easy way is to take 2 X-rays with a ring kit or an angulator. Think about it. When you open a space for a missing lateral, which tooth you are moving the most? You are moving the canine the most. And what you want to know is the parallelism of the canine compared to the centrals and the parallelism of the canine compared to the posterior segment. So these 2 X-rays are very practical and accurate guide during treatment for root parallelism. Now back to our case. We all use open coils to open a space. What does open coil do? Open coil separates the crown, but what we sometimes overlook is it also converges the roots, okay? Because you do like kind of tipping around the center of rotation. Our first cases probably ended up, we thought towards the end of treatment that we have a good space for a crown. And when you take an X-ray, we find that the tooths are convergent. And sometimes it takes like 6 months to get to root parallelism and you're at the end of treatment and maybe some root resorption. So to avoid this jailing, angulating the bracket from day one is a good idea, because what happens when you angulate the bracket from the initial arch wire, you start separating the roots from the initial arch wire. So back to our case, here are our spaces, equal space on both sides, at the crown level and at the root level, root parallelism. And this is the post-treatment. And here's the patient profile. You see that she grew her nose and she grew some chin. Like you can see it on superposition. There was a lot of growth, but her lips now are they are on the line. There is a good lip support. And here is her end result from a frontal view. And I published her in the Arab Dental Journal. And I had the chance to see her after that, 11 years post-treatment. And you can see the nice outcome as far as gingival level. And I saw her also 24 years post-treatment at age 40. And you see that it's a nice outcome. Now let's go to this patient. Again, we're going to apply, because the first decision is going to be whether we have to open a space or close. And we are going to apply the rules of profile, incisor protrusion, and space availability. We see that she has a proclined lower incisor, full lips. The lower lip is a little bit forward, and there is an arch length deficiency of 7 millimeters. So it's an extraction case. Extraction is not going to affect the profile, and it's going to be much easier than creating two spaces here. Now, even in space closure, root parallelism is still important. It's still important to take progress X-ray, not wait till the end of treatment. Here I had to rebound the brackets to get good root parallelism. I don't know if you're familiar with the Storner box, which is a very old wire. Now, I know many don't use it anymore. It's like it increased the flexibility only at the canine level here. And this is the end result. And this is the composite corners, what we call the composite corners. And you can visualize root parallelism, which is important for aesthetics and stability for space reopening. I'll talk about this. And then we routinely stabilize. We're going to talk about this. As expected, so it's like a 4 bicuspid extraction case here. The profile was not really affected, and it was a space closure. Now, this is interesting because this patient was treated orthodontically, and the restorative dentist referred her to me for a second opinion. He said, can you open a little bit more space, 2 millimeters on the left side and 1 millimeter on the right side, because here I cannot do restorative, I cannot restore them. Now, when I looked at, she has an overjet, she has, again, profile-wise, there is incompetent lip, protruded lower lip, there is an upper incisor protrusion, there is an overjet. Opening more space will increase the overjet. So I talked to the dentist and I said, you know what, this is a space closure case. He said, whatever is best for the patient. So she had an old first molar extraction. This is why you see this tipping of the teeth. So we had to do some balancing extraction, and you have two missing upper laterals. So again, it's like the previous case, 4 teeth extraction case, and there was some coronoplasty and buildup of the canine. By the way, this was published in the Jordan Dental Journal back in '99. Now, how do we transform a canine to look like lateral incisors? We still a little bit use what Everson said in the 70s. Why in the 70s? Because in the 70s, the only orthodontic option for missing laterals was space closure, because there was no implant, and they used to prefer space closure rather than doing a conventional bridge on a child and prep for sound teeth. So Everson came with this. Now we still do the same, but with some modifications. So how do we transform the lateral? Mesiodistal reduction, we rarely do unless the canine is really very small. Because the canine, very big, sorry, because the canine is a little bit larger than the lateral it's replacing, but the premolar, first premolar is smaller than the canine it's replacing, so they بيتبلوا بعضهم مثل ما بيقولوا. We flatten the tip, of course, this we do systematically because it's very anesthetic to have laterals. But that's the most important point that Taverson did not insist on, is to reduce the lingual surface, because the canine is thicker labiolingual. And if you don't reduce the lingual surface, you're going to have bulging, and the canine are going to be look out and very anesthetic and showy. So it's important, even if you can reach the dentin, you have to do that. Flatten the canine eminence, but you cannot here go too much because it makes them darker. Zachryson did an old study where he showed that it's possible to do extensive grinding without a problem. So our canine is going to look like a lateral. Now, sometimes you have very pointed canine. In these cases, removing making it flat, you're going to trim too much. Then you have to use what we call composite corners. But here the trick is to add composites, and this is what I tell to dentists. Sometimes I do it myself. I tell them, please add your composite only on the mesial, because if you add the composite on the mesial and on the distal, your canine, like you can see here, look at the difference between the two. It's the same size, but here the canine looks very bulky. So you add only on the mesial, and it's gonna look something like this. Now, ideally, the lateral is a little bit, the gingival level is a little bit lower. So we have to position the canine. In fact, when you are going to bond your case, you're not going to bond your bracket according to the incisal edge like we do on a normal case, but you're going to bond your bracket according to the gingival level. So here you want the canine to be at least at the same gingival level as the central, or better, a little bit lower. Okay. Then you have to put a little bit of lingual root torque to avoid the cortical bone and to reduce the eminence. But the problem is when you put lingual root torque, you're going to get an overjet because of this thickness. Thus, the importance of reducing from the palatal. Okay. You see, after lingual surface reduction, you reduce the overjet. And by reducing the palatal, you can extrude it more. I'll talk about this, okay? Okay, so here a clinical case. This patient went to his restorative dentist. She's missing a lateral here. This is a canine, and this is a bridge. So she said, I want to change the 4 anterior teeth. I don't like them. So the dentist said, you know, I can change them, the color, I can make it a little bit better, but the problem is your gingival levels. So he said, can you improve on that? Now, if you do crown lengthening, you're going to have very big centers. So what I did is I extruded the canine. So my brackets were positioned according to the gingival level, and I reduced the edge till I got even some overcorrection. And now the dentist, this is a temporary crown, and now a temporary bridge, and now the dentist can do his work and he can do a small gingivectomy on the existing lateral. Now, how do we position the premolars? Now, the premolars that are going to look like canine, there should be extruded and a little bit offset. But that's the most important point, mesial rotation. You want to hide this, the flat mesial edge, the flat mesial surface of the premolar. That looks very anesthetic when you smile. So this patient was treated orthodontically, and she wasn't happy with the result because of this. So after correcting the rotation, you see now the premolar is looking more like a canine. I hide the flat surface. And then you put a little bit buccal root torque to create a canine eminence. Okay, so bracket positioning, again, you want to position the bracket higher on the first bicuspid than on the second because you want to extrude it a little bit. And you want to position the canine bracket on the canine that's going to be a lateral at the same or a little bit closer to the gingival level to extrude it a little bit. You want to offset the bicuspid. And I said that, mesial rotation. So in order to get mesial rotation, you want to bond your bracket more to the distal. Okay, my bracket is mounted more on the distal here. And sometimes, you know, they are rotated. Many, by the way, first premolar are rotated. And you have to sometimes use some lingual attachment. But it's very important to hide this part. Okay, so to make it look like this. Okay, now I have a very nice gingival level here because I extruded the canine and make it look like a lateral. But now my gingival level is low on the first premolar that is becoming a canine. What are my options? I have two options here. What I can do is gingivectomy, which is not very, sometimes you cannot do it because the root is very thin and you can get open embrasures. Another option is to intrude and do build-up. Okay, so or you extrude and you do crown lengthening, or you intrude and do build-up. This is an interesting study by Marco Rosa and Zachrisson. Zachrisson came once to Jordan. And what they do is if you want differential intrusion and extrusion, look where they position the bracket on the first premolar, very close, so that they intruded, and they position the bracket on the canine very high to extrude it. And then they do a composite build-up. Okay, so what is the advantages of space closure? The advantage is the permanence of the finished result. You don't depend on a permanent restoration. Once the treatment is finished, you're done. It's shorter overall treatment, and it's lower cost. You don't have to go through fees of implants, and it's better aging as far as a color, as far as gingival level. And I give you this example of better aging. This is a patient, again, she has a protruded lower lip, an edge-to-edge bite. Arch length deficiency is calling for space closure, and the profile is calling for space closure. So it's an extraction case where I extracted two lower bicuspid and closed the space. Here is the end result. Look, she has a good profile now. Interesting enough, at that time, it was a long time ago. I proposed to do some build-up. She said, no, they look fine to me. We didn't do build-up, which is good. Okay, so the gingival level is fine. Here, the first premolar was extruded. The profile is it's improvement. She did a rhinoplasty. And here she is 20 years post-treatment. Okay, and that's what I want to show you. In 20 years, you change. And the color of the teeth is gonna change. The gingival level is gonna go a little bit apically. So when you have natural teeth, aging and gingival level is much better than when you have restoration. So that's the major advantage. So here she is 20 years post. So there are disadvantages to space closure. We're going to talk about these disadvantages. The first is space reopening. This is why systematically you have to have bonded twist flex, permanent retention. The second disadvantage is occlusion, and three is the canine. I'm going to talk about now occlusion in space closure. Whether you do non-extraction on the lower arch, class 2 molar, or extraction on the lower arch, class 1 molar, in both cases your canines are in class 2. At some point we worried TMJ problems, you don't have canine guidance, but research have shown that you don't have a problem, occlusal problem, let me say. But as I'm going to show you later, sometimes you have problems, you cannot get good seated intercuspation like with space opening. So let's talk about the canine. The canine sometimes is unfavorable for space closure. As far as color, as you can see here, look at the upper canine, look at the lower canine. Her canines and the molars, her canines and her molars are very dark. Of course, we can do individual tooth bleaching and porcelain veneers, but then you go into a restorative cycle. Then you have the size and the shape. Some canines are very large, and especially in unilateral space closure. And like in this case, sometimes some canines have a very huge eminence. And then you have the gingival level. Okay, so let me show you this case of space closure. There was a build-up on the mesial, but typically sometimes, okay, aesthetically it's nice, the gingival level, the size of the canine, but the occlusion is not seated 100% perfectly. This, you know, believe me, in many, I know Marco Rosa, my friend Marco Rosa and Zachrisson, they want to treat everybody with space closure, but I'm sure they get cases like this where they cannot see the occlusion perfectly. We have to recognize that this is one disadvantage. Another disadvantage is, look, when you look at her smile, well, you see that the canine, which are lateral now, they're a little bit prominent. Okay, they're bulging a little bit. And if you reduce them labially too much, you can darken the tooth. Okay? So I'm going to talk about the ideal canine. Of course, this canine is not an ideal canine for space closure. It's oversized. And look at the gingival level. There is no way you can improve the gingival level because the canine is so bulky labiolingually. You have to trim almost half the canine if you want to correct this bulging, this offset, if you want. Okay. On the other hand, look at this patient. Okay, this patient has a big arch, small teeth, so, and there is an available space of 10 millimeter. So as far as arch length deficiency, it's a space opening. The profile also, and he has a short lip, but he can afford pushing the lips a little bit outward a little bit. So it could be a space opening, but it has an oversized central compared to the average norm. This is the norm. Sorry, can you see my pointer? Okay, this is the norm. So this is oversized. Now the canine is undersized. The canine is 7.59. It's smaller than the regular canine, than the average canine, and it's close to the size of a central, of the lateral. So this canine is really favorable for space closure. This is the ideal canine for space closure. First, it has the same color as the central, as you can see here. It is narrow at the CEG. It is narrow labiolingually, not like the one we saw. So if you trim it a little bit from the palatal, it's not going to go out too much. The gingival level is already at the same level as the central, so we can extrude it a little bit. And it has a flat labial surface. So these are the criteria of the ideal canine for space closure. This is after space closure and before build-ups. If you notice, the crown are a little bit conical shape. So the dentist did a nice build-up here in the middle and a build-up on the mesial. And this is the end result. Now, all is fine as far as the canine that became a lateral, as far as gingival level, as far as color, and as far as size, mesiolingually, and as far as offset, the canine are not bulging out. But the problem is that here. So what our option now is to do crown lengthening, or before doing that, I want to look at, see, my cervical line is not straight like it should be. But this particular patient has something we call reversed upper lip line. So his upper lip line follows the curve of the gingival level, and it doesn't show. So we didn't do it. You see, this is a close view. So we left it the way it is. So it's all natural now. The profile, he grew some nose and some chin, but the profile, as you can see now, was not compromised with space closure. Okay, this is a patient. Again, we're talking about favorable canines. Now, this patient, if I apply the profile and size of protrusion space availability, I think you all agree that this should be a space opening or a non-extraction, because this patient doesn't have a lip support, and there is no arch length deficiency, and there is space for the missing laterals. But there is another thing here, is that the canine is favorable to be a lateral. So this is a situation where look at the gingival level first, and then look at the size. Okay, the canine is 6.9. Okay, the average size of a lateral is 6.7, 6.8. So the size is perfect, the gingival level is perfect, the color is perfect, but it's a non-extraction, it's a space opening. So in this case, we're gonna leave the canine where they are and put the implant at the site of the canine, replacing after we extract the primary canine. What is the advantage of doing that? Of course, we can't do it unless the canine is favorable. The advantage is, first, it's shorter treatment time, because when you bodily move the canine back into its site, it's longer treatment time. But the second major advantage is that this canine, primary canine, is going to act as a space maintainer and as a bone maintainer, and the patient will not rely on a removable retainer to replace the missing teeth. Okay, so the profile almost stayed the same because we didn't move teeth anywhere. And here she is waiting for end of growth. Her sister also is missing laterals, but and also has canine at the site of the lateral. But there is a big difference. Her profile is right, and we can go either way. But the big difference is that she has an arch length deficiency of 10. So her sister, I'm gonna, of course, treat her with space closure, unlike the sister, because of the arch length deficiency. Plus, her canines are also very favorable. The central is a little bit oversized, so a lateral of 7 millimeter will be very good with a central of 9. You know what I mean? These are the average value. So the central is oversized, and it's a class 2 molar, so we finish in class 2. Why I am insisting on comparing these cases? Because I want to go back to the importance of indication. Space opening is indicated in distant profile or normal profile, in dental retrusion, uprighted incisor, and when you have an arch length, when you have a zero arch length deficiency, or you have enough space. It's those indications for treating non-extraction. Space closure is the indication of extraction when you have full lips profile, dental protrusion, and lack of space in the arch, and sometimes when you need to extract in the lower arch. Why I'm insisting? Because at some point, if you remember, the late Vince Cockage introduced this very interesting counterpoint in the AJO, where you promote different treatment modalities. And here they presented this like, which is better, space closure and space opening? And everybody, of course, Marco Rosa and Zachrisson defended space closure. So everybody started to defend one treatment options. In fact, there are indications. And what we should do is to see the pros and cons of space opening versus space closure. For example, if the canine, like the one we saw, is oversized, we're not going to do space closure. Okay. And we have to discuss with the team member and with the patient, of course. Now here, for example, a systematic review. And again, you know, it's like this review is promoting space closure again. You know, 2 supported dental prostheses had worse scores as periodontal index. Space closure is better aesthetically than prosthetic replacement, and it shows better occlusion. Okay, it's better aesthetically, not always. If you have an oversized canine, it's not going to be better aesthetically. If you cannot trim much from the lingual, your canine are going to be bulging. It's not going to be better. So again, depending on this, on the cases, and this is why I want here to show you this unilateral agenesis. Any knowledgeable restorative dentist will tell you that there is no way now he can give you symmetry with a very undersized, peg-shaped lateral on one side and a large, huge canine on the other side. He simply, or she simply cannot give you 2 teeth that are equal or symmetrical. Okay, so we have to go for space opening, unilateral space opening, or extract the peg-shaped lateral and close the space. Here is exactly a very similar case where also unilateral agenesis, where you have a peg-shaped lateral on the other side. Okay, they had exactly the same arsenic deficiency. So what's better? Space closure for both? Space closure is better? Well, there's no way I can do space closure on this patient on your left side, on the boy, with such a distant profile. On the other hand, yes, I can do space closure. The lips are not really flat here. So let's go for this one. Nasolabial angle, open, midline shift. So I'm going to open the space, discuss it with the dentist. He has uprighted incisor. We're talking about incisor protrusion. And I'm going to open the space, and the dentist is going to build up the lateral on the other side. Of course, good root parallelism, implant in place. And here's the end result. Okay, managed to grow some nose and some chin. But if you notice, by proclining the incisors, we gave him some lip support, and we're able to compensate for nose growth and chin growth, as you can see. And here's the nicely seated class 1. He started with a class 1, ended up with a class 1, which is easier. So space closure is really easier here for this patient. And this is the end result. And please notice the nice profile, nice. Okay, let's go now for the other patient that we decided we're going to close the space. Notice how I rotated the first premolar mesiolingually to hide the flat surface. Because it's an upper extraction only, I rotated the molar, get a good class 2 seating. This is before any build-up. The gingival level is very favorable. The canine, if you notice, there is a little bit offset so that it looks like a first premolar, looks like a canine. It's a full class 2 on both sides. And we hide the flat surface of the first premolar. And this is the composite build-ups made only on the mesial, only on the mesial. I don't want it to look huge. And this is the end result. Okay, there was a lot of growth with this patient, but again, the profile followed exactly. Okay, I want to compare this patient that we treated with extraction, space closure, to a very similar patient, again, unilateral. Her profile looks a little bit fuller. She has a tendency to some protrusion, but not too bad. What's the difference between the two? The difference between the two is that the new patient on your left side has a larger existing lateral and a smaller canine. Did you get that? Larger and smaller. So what I did here, I treated with unilateral space closure. I am in class 1 on the right side, the canine in class 1. I leave it the way it is. We build up the lateral. And here I am in a edge to edge. I move to a class 2, close the space closure unilaterally and build up on the mesial only for the canine and build up the lateral on the other side. Always good root parallelism. As expected, we didn't change anything. The profile is looking good. And now if you look at a close-up view, midlines are on. You see that the gingival level is a little bit higher on the canine that replaced the missing lateral, but her smile can afford this. She doesn't smile really high. So it's a good outcome. Okay, talking about indications again. Here's a patient, it's a class 2 division 2. Okay? Now, we all know that usually class 2 division 2 are treated non-extraction because we have severely retroclined incisors. This particular patient also, the profile has a tendency to be dished in. And I have enough space. My arch length deficiency is 0 here. Okay. Honestly, it is, for me, it's impossible to treat this patient with unilateral space closure because I have a lot of spaces here. There is this primary canine and the incisors are already retroclined. So there is no way I can treat, of course, not by extracting the existing lateral, not closing the space both sides, not even like the previous closing the space on one side. Okay. So I'm going to open the space. And this patient is a very old patient. We were just starting with implants. And I was lucky to work with a very knowledgeable implantologist. He said, you know what? There is a concavity here, and it's better to do a bone graft. So the patient was a little bit reluctant with implant already, and he rejected the implant solution. And we did a Maryland bridge, type of Maryland bridge, but with pins, because as you know, the Maryland bridge has a high rate of failure. And you see, that's the problem with this concavity. If you cut the model, you see when you don't make a bone graft, your implant is going to be too much inclined, or your implant is going to have too much palatal root bore. And the restorative dentist has to compensate, and he's going to do an angled abutment that might lead to recession or metal show. So that's the importance of bone graft. That's an end result. It's an non-extraction case, it's face opening. And you see, he has a much, despite it's a lot of growth, but look at the lid support now. And of course, the smile. Now, space opening. We have disadvantages of space opening when we use an implant. Okay, it's not like with every new technology we think that implants can resolve all our problems. The first disadvantage is we need to do bone graft in most of the cases. Why? Because when you open the space or you procline the incisors to open the space for a missing lateral, you're moving the teeth out, the bone is following. But when there is no tooth on the lateral, missing lateral, the bone is going to stay behind. So you almost always need, if you want to do a good crown, a good implant. And then you have the risk of metal transparency. This is why 3D repositioning of the implant is very critical. And many knowledgeable restorative dentists, they like to go attend surgery to make sure that the implantologist is putting the implant where they want it to be, 3D wise, and some bone substitute here. So it's technique sensitive. Another disadvantage is that there's this tendency to intrusion even in non-grower. Okay, even if you put the implant at the end of growth, with some patient there is a tendency, there is a continuous growth. Then there is the problem of color and aging, and of course it's longer treatment time and higher cost. Okay, this is okay. Any restorative dentist will tell you, okay, this patient looks like he doesn't need orthodontics, nicely seated class 1, but any restorative dentist will tell you with 4 millimeters I cannot do much. Okay, again here, this is an old case, but we did without bone graft. Okay, when you do it without bone graft, we optimize the spaces for the restorative dentist. But, when you don't put a bone graft, the implant is higher because where there is bone, and you end up 7 years post-treatment having some intrusion. That's one disadvantage. Some metal transparency. Okay, because you're putting your implant a little bit higher in where there is more bone. He's not complaining about it, and I was ready to tell him if he complained about it that you lost all your hair, so 1 millimeter is not a problem. But he was happy. Okay, again, let me go back to major decision whether we have to open the space or close. Now, the profile, you all agree, codes for space opening. Very uprighted incisors, this in profile. Now, unfortunately, the arch length deficiency, 10 millimeter of lack of space here. There is, the canine did not erupt yet. And we don't have space. So the space availability is calling for space closure. Even the lower spaces, lower arch is calling for extraction. It's a class 1. So for profile consideration, it was a little bit challenging, but we decided to open the space. Get some space, we had to do some expansion. And this is the end result. There is a small lateral that had to be built up. And here's the canine that was impacted, built up on the lateral, and this is the implant. This is a close-up view of the implant. This is her smile. This is her profile. Okay, a much better lip support after space closure. And here she is 10 years post-treatment. And it's a nice outcome, actually. And here space opening was important. Okay, now the question is how much space we should open for a missing lateral. The average size, if you open an anatomy book, is 6.5 millimeter. But again, some patients have large teeth, like on your left, and some patients have small teeth. So there is no one size fits all. What governs that space is aesthetic and occlusion. Occlusion, once you get good overjet, overbite, your midlines are on, your canine is seated in class 1, that's the space you need. Plus aesthetics, of course, the stools should be in harmony with the adjacent central incisor. A golden proportion is not an accurate way to measure, because golden proportion is how you see it from a frontal view. It's not the real mesiodistal size. The real mesiodistal size is, now I don't want to give you numbers or a magic number, but it's if you take the average sizes, a lateral is 0.77 point central. This gives you an accurate number to start with. Or if you follow the Bolton and you end up with 0.78, which is very close to the central incisor. Now, for sometimes we were very rigid on finding the exact size. Till this study from Rockage Jr., the son of Vince, what he did very quickly, he took a computer image and started to change. Here, for example, he took a lateral, make it 1 millimeter smaller, 2 millimeters smaller, 3 millimeter, 4 millimeter. And then he did other parameters. He moved the midline, he saw more gingiva, and they mixed all together. And for the laterals, it's interesting because general dentists and orthodontists noticed or rated anesthetic the laterals when they are 3 millimeters smaller than their average size. Yani almost half the size. Lay people 4 millimeters. The conclusion of this study is laterals were not detected until they were 3 millimeters narrower than ideal, which means that leaving symmetrical narrow laterals may be acceptable. Okay, so if I show you this smile, okay, and if I tell you, okay, I can't do that, raise your hand who would see this smile as attractive. I'm sure most of you would have liked this smile or rated maybe good or excellent. Maybe a close-up view also. And not, most of you would have rated excellent the occlusion, seated canine. But look at the laterals. She doesn't have a missing lateral, but her laterals are undersized. They're only 5, and her central is 9. For this patient, if she was missing lateral, I would have thought of a lateral that is 9, that is maybe 7 millimeter for a central that is 9. And yet, aesthetically, so the conclusion, or what we reach now with the study of Vince, the size is not really rigid. The important thing is to make it symmetrical. This patient came to me for a second opinion. She wanted to redo her orthodontic treatment because her laterals is small. I talked to her about the study. I said, you are focusing on these. This is why you show and you see them small, but people are not seeing them, and I don't really, it's not worth it to redo all your treatment. Now, in this particular case, the occlusion is a little bit compromised because of the size of the laterals. Okay, now here we are on 2 similar intraoral patients. Both have 2 peg-shaped laterals. They're identical and missing laterals on the other side. But their profile is completely different. Okay? So you can guess that on the patient on the left, I'm going to go for space closure. She has a class 1 and class 2 on one side. So I extracted second premolar on the lower, on the edge class, and here's her end result. Okay, it's like 4 bicuspid extraction. The peg-shaped lateral and the missing lateral, which make 2 teeth on the upper and 2 premolars on the lateral. Nicely seated class 1. You can see that the profile was not affected. She had some strength deficiency. And here she is 11 years post-treatment. And she looks nice aging, the color, the gingival level, seated first premolar in canine, seated class 1. Okay, for this patient, at that time, I proposed to her surgery. Space closure, extract the peg-shaped lateral like the previous patient, don't extract on the lower, create an underjet, and advance the maxilla, and do some genio. Well, her answer was, I'm not bothered by my profile. My whole family looks like this. So we rejected surgery. And at that time, we started to have small implants that are 3 millimeter, not the standard 3.75. So the dentist tell me, yes, I can do a small implant, which made her lateral look like 5 millimeters on one side and 5.5, which is very small. But again, aesthetically, we were able to give her a papilla, but aesthetically, she was happy. She wanted the symmetry she got. Okay. Now, this is a very similar case. Also, shape and missing on the other side. This patient has asymmetry, chin asymmetry, and paranasal hollowing. But this patient accepted surgery. I said, surgery is better for you, especially for the asymmetry. You have a class 3 tendency. In this case, yes, I removed the peg, created the underjet I needed, and now I have a midline shift. Why I have a midline shift? The lower midline is shifted because the whole chin is shifted. And this is going to be corrected surgically by mandibular rotation, maxillary advancement. And here's the end result. Symmetry is corrected. And I gave him a fixed retainer, of course. He was not very regular. He lost his retainer and waited, and came back 6 years post-treatment. I said, you didn't come back regularly. Why do you come 6 years later? He said, because I lost my retainer. And you know what? He had a space opening. I was very bothered, and I said, okay, we can, I gave him the option. He said, no, it doesn't bother me at all. Not at all. And it's interesting because this is a study where it shows that lay people tolerated a wide range of variability for most smile characteristic more than us. And sometimes we see something very big and the patient, they don't care about it. So sometimes we have to be cautious about sometimes over-treating patients for a small space that they don't bother. I was not going to do braces again, but maybe build up or something. He didn't accept. So this is just to tell you, sometimes he was happy. He was happy with the outcome. Okay, we are 1 hour now. I think I'm gonna go for 10 more minutes, if it's okay.
Okay.
Okay, this patient, I told the mother, she's biretrusion and uprighted incisors, has an impacted canine, missing lateral. I told the mother, you know what? We better do surgery. But when you tell for a mother, 12-year-old, he needs surgery, if you use the same expression in Jordan, يقبر أمه إنه بيجنن الصبي, how he needs surgery. She rejected surgery, even though I made a simulation like this and I showed her, I said, with surgery, it's going to be much better. And had she accepted surgery, I would have gone for space opening, implant, and mandibular advancement. Space opening would have advanced the upper lip, gave him upper lip support, and I would have created an overjet, and the surgeons have advanced the mandible. We had to go for space closure, and as expected, this is the end result. Okay, so I don't know if I made it a little bit worse, maybe not, but I really don't like this profile. But she was happy with the outcome. It's good that all the mirrors in their houses, they don't show them in profile. And it's okay, smile-wise, occlusion-wise is okay. The profile would have been better with surgery. Okay, very quickly, again, this is a borderline case. She doesn't have a good lip support. But on the other hand, she's a cleft patient. On the other hand, it does not justify surgery or maxillary advancement. So A and B is 0, which is -1, borderline. But because it's borderline, we have to open the space because I want to give her better lip support. I want to proclaim the incisors. In fact, for the story, she went to the dentist, and because she wanted to get married in 3 months or 5 months, she told the dentist, I want to do Hollywood smile. The dentist told her, no way, you need orthodontics, you have a crossbite, and you have sound teeth. So I explained to her everything, and she was really aware, and she was very excited about treatment. I said, no, we want to expand, correct the crossbite, open the space. This is how we seated the canine. I use super glue sometimes to hold my plastic teeth. It works very well. Root parallelism space is at 3 levels. It's a 3.75 millimeter implant here because it's a big lateral. Space opening, again, as I said, I'm gonna go fast on this one. We angulate the bracket so we get root separation from day 1. I'm seated in class 1, midlines are on, I have the space, but what happens when you broke-line your incisors? The bone goes out with the teeth, but where there is no teeth, the bone stays behind. And you get this wagon wheel effect, and you get this depression here. So she had to do a ridge augmentation that we took from the symphysis and bicortical bone angles. Here's the end result. Nicely seated class 1, the canine is seated in class 1, nice color, gingival level, nice arch. And in fact, look at the lip support, upper lip support. You can see it on the superposition, the lip was behind. And she was so excited with treatment that I proposed to her before she get married, I can remove the braces and give her a flipper. And she said, no, she got married with the braces, but was smiling like this all the time to hide the braces. And I published her in the EGO and saw her 20 years later at 50, and you can see the nice outcome as far as gingival level. Okay, this is a patient that finished orthodontics, went to a restorative dentist. He said, no way, there is no way we can put implant here. Okay, you have to do braces again. So I had to, now because the incisors were proclined, the more you procline the incisors, the more your roots get closer together, converge. So what you do is, here I angulated the bracket and then I used this type of loop to increase flexibility and distal drive the root of the canine and mesial drive the root of the overcorrected the parallelism. I will go fast on this one because of time. This patient had a lateral, and I said, great, we're going to manage. And she had some enamel defect here. I said, we're going to do build up on the central and build up on the canine, on the lateral, peck shape, that there's a cleft. The dentist decided he prefers to do a crown, but the patient was very unhappy with the outcome because there's this black triangle here. He tried to add composite, and then we ended up with an oversized central. So we had to go over again. Now, if you can see it on a 2D, he said, okay, why don't you move, Roy, the roots mesially, build bone. In fact, it's a cleft, and there is no cortical bone, labial and palatal to build bone. So the only solution was to extract the central, the lateral, and do a bone graft. And then we did some connective tissue graft later on that we took from the palate. Fill this, and we ended up all like this. Okay, nice fill up of this was the black triangle before. Here she is 13 years post-treatment. In fact, when I look back, okay, probably before the eruption of the lateral, I should have done some secondary alveolar bone graft and let this lateral erupt into the bone graft. Okay. Now, timing for implant placement. We know we have to put implants at the end of growth. Oddman said, told us, and we know from ankylosed primary teeth, because we all saw ankylosed primary teeth, how they stay behind, you know, the step. Oddman did this study, I don't know how they did it, but they did it on growing patient. They put 27 implants on growing patient to realize that they ended up with a step. So when is the end of growth? Of course, it's not the bone here, desmoid bone. It's not the fusion of the radius and the epiphysis, because remember, all these are averages, okay? Average values, and they don't apply to the patient living in Amman and sitting in your chair, or the patient living in Beirut. These are average values from another group of patients. Do not apply to our patient. What apply to our patient is, okay, this is a study where they find that it's around age 20 that you should put the implant. Again, this is not very accurate. But the best way to know when the end of growth of our individual patient is superposition tracing. And for boys, we wait till 18, 19. Boys continue to grow till 20. So at 18, 19, we can take a first TSF and do another 8 months later till we get to this complete superposition. For girls, we can do the first CEF at age 16. Okay, this patient, I did this superposition was for this patient, which I did the implant at age 17. There was good no growth on superpositions. And I saw her 12 years later. You see the step? Where is my yellow arrow on the right? Okay, so even at the end of growth, restorative dentists and implantologists will tell you some patients there is continuous growth and you'll get a step. And this is, the evidence is in this study. Now, how do you hold the space? Because most of these patients, we start at 11, we finish at 13, at 14. Sometimes there are 2, 3, 4 years of growth. We all use this type of retainer. I like to add some wires here like this to make it more. Sometimes they break the teeth so the wire can hold it. Now the first question is, what about root parallelism stability? You paralyze the root at age 12, 13. Will it stay parallel till age 18? And my second question is, what about root resorption? Okay, does this bone resorb? Okay, first, root parallelism. This patient at the end of treatment, 49, she's a girl. And here she is at age 17. Relapse of root parallelism. Okay, this is very rare. It happens with friends and family. In fact, her brother is a friend. He's a periodontologist. It always happens with friends and family. But in fact, what is the explanation of root reapproximation? One explanation is when you have significant vertical facial growth, when you have compensatory eruption or inadequate spade maintenance, and if the patient didn't wear his retainer well. One way to stabilize root parallelism when you have a lot of growth remaining is to do a temporary Maryland bridge. Okay, this bridge is not going to only hold the crown space, it's going to hold the root parallelism and will avoid dependence on removable appliance that they might lose or break. You can also use this type of Maryland bridge, or this. Some will do it on a wire like this, and they build up composite on the wire. But again, I don't think these are as stable as a Maryland bridge done in the lab. Sometimes we use mini implants as a temporary crown. Some believe they hold the bone, but the bone is not a problem really, because I'm going to talk about bone resorption. This is a study that looked at alveolar ridge narrows 34% over 5 years when you extract a maxillary incisor. Okay, you lose because the alveolar bone goes with the teeth. Now, Kokage and Spears, Matthew and Spears, they did the study, and for space opening, they took study models after space opening. They cut the model in two, they measure, and they took the same study model, another study model some years later, and they found that you lose less than 1% over 4 years. So for the question, do you lose bone when you open a space for the missing lateral? The answer is no. Okay, but one way to do it is to favor, whether it's a space closure or space opening in the future, you want to favor an eruption of the canine at the site of the missing lateral. Why? Because the canine is a big tooth and it brings bone with it. So here, not for aesthetic reason only, but I'm reapproximating those centrals so that the canines erupt at the site of the missing lateral. They bring bone with it. You see where the canine are. Now I can reopen them for implants, but I have a lot of bone that came down. Let me finish with this. This is just to show you a very rare situation where you can retain primary incisors. This patient is missing incisors. I saw her at age 6, and she lost here her primary central. Here is the primary laterals. I opened the space for the central to erupt. And these are the laterals, okay? Primary laterals, primary canines. And here I was ready for the second phase. And I left them. I treated her with her primary laterals. At age 69, she has her primary laterals. 2 years post-treatment at age 18, her primary laterals are here. They look good as far as space, size, and even color. And here's her X-ray. Retaining primary. Now, I know that you can retain primary molars when you are missing second premolars. It's an option. But usually retaining primary lateral is very rare. You know, it's just a rare case I wanted to show you. Of course, you cannot retain these laterals because you already have a lot of root resorption, and they're very small with big centers like this. But it's an option. This is an old publication of mine in the Journal of the American Dental Association. You can read it. It's still valid. I mean, it goes through what I said, but you know, of course, I said something new now. But it's still basic material still there. This is another one in French, more recent. Okay, I want you to go with this take-home message. For space closure, if I want you to remember 2-3 clinical tips. One is make sure you reduce the palatal side of the canine that is going to replace the missing lateral. Why? Because you don't want it to bulge out. Remember from your dentures, you'd always put the lateral with small inside to the inside, okay? If it goes out, it's gonna be very anesthetic. You build up only on the mesial so that it doesn't look huge. For premolar, you don't want to show the flat, it has a flat mesial end, mesial side. You don't want to show it. So rotation mesiopalatally from day one. You bond the bracket more to the distal. Always fixed retainer. Spaces always would like to reopen. There is no transeptal fiber between these. The space will reopen. For space opening, angulate the bracket from day one because you want to separate the teeth from day one. Take progress PAs. PAs are enough for root parallelism during treatment. Take progress. Don't wait till the end. How much space? Symmetry is more important than the rigid 0.77 descendant, okay, or 6.5. Symmetry. If you have a lot of growth remaining, to avoid root reproximation, Maryland Bridge. Make sure that you need 1.5 at the crestal bone level. You have to leave 1.5 millimeter between the implant and the tooth. If not, you might have bone necrosis and no papilla. So, or use a 6 millimeter implant. And bone graft is important if you have a labial convexity. If not, the implant is going to have too much palatal root torque. The restorative lentis will angulate too much the tooth, and you're going to have recession, gingival recession, and metal transparency. And consider when you have a very favorable canines that in space opening that erupted at the site of the missing lateral, and they're very favorable as far as size, shape, and gingival level, considering putting the implant in the canine area. It has a lot of advantages. And I thank you very much for your attention. And I want to, you remember, I don't know, some of you Remember when Brandmark visited Jordan, I was there, and Brandmark saying, surround yourself with some of the best minds in the field and you're bound to success. So surround yourself with a good restorative dentist, a good implantologist, and you are bound to succeed. And be a good orthodontist. Follow my advices. Thank you very much.
Thank you very much دكتور روي. محاضرة رائعة، سلم ايديك. بدي اذكر الزملاء انه الاجابة على الاسئلة نقاط التعليم الطبي المستمر بيضغط على ليف ميتينج، بيطلع لهم صفحة جديدة بيجاوبوا على الاسئلة. طبعا برضه مرة ثانية بأكد على الزملاء رجاء، أول ما نبعت إحنا الانفيتيشن للزوم نسجل من أولها، لأنه في مانيوال أبروفنج وراح يجيك إيميل وعليه الباسورد. هلا حسب سياسة زوم من 8/5 اجى الايميل اي ثينك، او 7/5، الدكتور شادي بيصلحني صححني انه لازم نحط الباسورد الايام هاي، صار فور مور سكيورتي ريزنز. وبرضه بطلب من الزملاء للحصول على ساعات التعليم المستمر مينيمم لازم يحضر المحاضره من 75 ل 80% عشان زوم تطلع الريبورت وتعطي الشهاده. اهلا وسهلا بالجميع. رح نفتح باب الاسئله. عندنا أول سؤال دكتورة مريم، أهلا وسهلا فيكي. دكتورة مريم العبد الله. Many thanks for a wonderful lecture, Dr. Roy. Her question is about retention. What retention regime do you use? Is it different between open or closed space cases?
This is a very good question, and I'll tell you now. For space closure, systematically from canine, central canine. Systematically, okay, on all patients, plus your regimen. What do you use when you do orthodontics? Do you use a regular Holy retainer for 6 months? You follow your regular regimen, okay? Now for space opening, when you put implants, now if I had initially a very large diastema between the centrals, I still put a fixed retainer on the 2 centrals only, because even if you put implants, sometimes your central open like even if a 1/4 millimeter, and some picky patient will tell you, is the space is reopening. So it's better to, if there is initially a large diastema, to
ممكن
put
تسوي
a
فرينكتومي؟
fixed retainer on both centrals.
ممكن تعمل فرينكتومي كمان if the diastema is too large ولا there is
إذا بدي أعمل فرينكتومي بعملها after space closure, not before.
طبعا. Yes.
Because if you do it before, you get scar tissue بيضايقك بالspace closure, and then you have to do a correction gingivectomy afterwards. So I do it at the end. But most of the time, when you close the space, the frenum migrates naturally.
اوكي، عندنا سؤال دكتور علاء الدين ابو خلف برضه بقول لك thank you Dr. Roy for this valuable clinical tips. When closing the space, do you put the bracket of the lateral on the canine?
Do you put the bracket
of the lateral incisor؟ يعني البراكت تبعت اللاترال.
لا مش بالضرورة. I can put the bracket of the canine because شو بيقولوا it fits better يعني. It fits better because the bracket of the canine is a little bit curved. Now, depending on the canine, if the canine is flat, you can put the bracket of the lateral. If the canine is really not very flat, you can put the bracket of the canine. But it's important to angulate the bracket. If you're closing the space, you want to to make sure to stress on root parallelism. Yani look at your radiograph, see where the roots are, and bond the bracket accordingly, even in space closure. Okay.
Okay. دكتور رياض البطيخي.
أهلا رياض.
دكتور رياض بسأل if you have space available in one side, what you prefer to do, space closure or space opening? In space closure, sometimes the canine is large and darker. Do you still do space closure?
I'm not seeing the question here.
لا هو مش موجود، هو حاطه على الشات.
على الشات يس.
معلش بدي اعذبك، ارجع عيد السؤال.
رفع ايده دكتور رياض بده يمسي عليك، هلا بنعطيه allow to talk. يا انا يا الدكتور شادي whoever gets there first. دكتور رياض.
مساء الخير.
اهلا رياض،
كيف حالك؟ طمني عنك.
والله مشتاق لك ومشتاق لكل اصدقائي.
اولد فريندز، يعني هذه عمر طويل عشرتنا نحن وياك.
اكيد.
السؤال الاول، اذا كان في عندنا one side space and the other side we don't have space.
عم تحكي عن you have bilateral missing.
bilateral missing.
Okay.
one side في space, the other side we don't have space. So what we'll do, closure or opening.
هاي بترجع لعدة closure or opening، يعني هيدي مثل ما حكينا بالأول، هيدي بترجع للبروفايل، للانسايزر انكلينيشن، للهاو ماتش arch length deficiency، يعني هيدي بتطبق عليها هالكرايتيريا لنقرر إذا بنفتح أو نسكر. بعدين أكيد إذا بوردر لاين بتطبق عن الكيناين كيف هي. Is it huge? Is it very dark? اوكي.
سؤال ثاني دكتور رياض.
السؤال الثاني اللي كتبته انه اذا كان عندنا
جامي سمايل.
حطيتك يا
جامي سمايل.
مش الجامي سمايل. اذا كان في عندنا large canine, we want to close the space and we have large canine and dark. Do we go for space closure?
اوكي. كمان يعني كمان هيدي بدنا نحط مثل ما بيقولوا بالعربي نحط بالميزان. كيف يعني as I said فرجيت ال AJO space closure versus space. as I said بدنا نقيم البروز والكونز، بدنا نشوف هالكيناين قديش رح تطلع بسعة قدام. وهلا اذا الحاله اكيد هي سبيس كلوجر، ما عندنا غير تشويس، يعني في arch length deficiency كثير وفي فول ليفت بروفايل ومجبورين نسكر، ساعتها we have to discuss with the dentist, restorative dentist.
Yes,
اذا في يعمل فينيرز، يا اذا فينا نترك له سبيس شوي.
Absolutely.
Okay.
The last question about gum smile. If we have a patient with gum smile, do we affect our to go for opening or closing? Patient has a gum smile, has yani smile, big smile.
Better to treat the gum smile. بس
gum smile رح يبين الروتس تبع الكناينز اذا سوينا كلوجر.
مزبوط.
بنفس الوقت اذا كان حاله بحاجه للكلوجر شو بنسوي؟ كمان في ريستوراتيف.
ليك رياض، when you have a gummy smile كلها صارت اصعب، لانه الجنجبل ليفل رح تبين والكيناين اميننس رح يبين. So it become gummy smile makes it a little bit more tricky. يعني it adds challenges to the case.
It's difficult cases, I know.
Again, we go back to it's something you have to discuss with the patient and with the periodontist and the restorative dentist.
Yes, absolutely.
Some patients will tell you, I don't mind about my gummy smile.
Absolutely.
Some patients will tell you, no, I hate my gummy smile and I hate my canine amylin. And then you have to go for something else. Then you have to go maybe for maxillary surgery, crown lengthening, depending on the case.
Absolutely. Thank you.
رياض, thank you لك على الأسئلة.
دكتور رياض، باسمي واسم الهيئة الإدارية لجمعية تقويم الأسنان واسم زملائي كافة في جمعية تقويم الأسنان الأردنية، بنشكر أخونا وصديقنا وأستاذنا الدكتور روي صبري على هاي المحاضرة القيمة. إن شاء الله بنشوفك سون مرة تانية بعمان.
أنا بشكركم كتير، وبتعرفوا قديش يعني أنا من البيت، يعني أنا بتتذكر ما بعرف بيو رشادي بتذكر من أول أورثودونتيك كونغرس كنت موجود
طبعا.
رياض، سامي سماوي. So أنا يعني it's a pleasure for me anytime. Okay. If we want to continue with Zoom, it's a pleasure. بس في شرط عندي انه وقت تفتحوا انا بدي اجي على عمان.
اهلا وسهلا فيك.
اهلا وسهلا فيك.
هذه حبة التيكت.
خلص ولا يهمك.
دكتور روي يعطيك العافية دكتور.
سلامي جميعا.
شكرا
لسه بدي اسهرك كمان شوي دكتور روي.
هات نشوف.
شو رأيك نسهرك كمان 5 دقائق؟
ايه with pleasure.
تفضل اذا في سؤال اكيد.
طيب لا هو انا يعني بدي اسهره للصبح اذا بدي اسال كل الاسئله، فبس بدنا شوي نسهره.
تمام.
دكتور روي, do you prefer to reshape the canines, especially grinding from the tip of the canine before bonding? This is the first question.
لا عادة بحب اترك الريشيبينج للاخير. لا لانه I'm afraid maybe I reshape a little bit more. So I يعني usually we like to keep it till the end. And sometimes we extrude a little bit, we intrude at the end, we depending on the gingival level, and so it's better. ما في عجلة يعني بالريشيبينج. هلا انتبه اذا الكينان كثير طويل، التب تبعه كثير طويل I can remove a little bit يعني. بس I don't remove the exact amount يعني. I just remove just a little bit يعني. Okay.
طيب سؤال ثاني. Do you prefer to use the bracket, for example, of lower premolar, or even like Dr. Ala said, bracket of lateral incisor on the canine, not because of the convexity of the labial surface of the canine.
Because of the prescription?
Yeah, of the torque, because when you close the space and the canine replace the lateral incisor, usually you have to reduce the canine eminence, and the torque should be positive now, not negative like rote prescription.
Okay.
So what do you prefer?
طيب هلا انت فتحت موضوع شو بيقولوا فتحت بواب مغلقه. ليك انا I don't believe much in prescriptions. يعني انت وقت تروح عند زارا لتشتري سويتشر مش معقول يكون في سايز واحد للكل يعني. انه الامريكان عملوا سمول وميديوم ولارج، رجعوا شافوا حالهم ما بكفي عملوا اكسترا سمول واكس اكس ال واكس اكس. So there is no one prescription that fits all, especially in missing lateral. شو ما كانت البريسكريبشن وشو ما حطيت البراكت صدقني بالاخر if you want to have an excellent finishing you're gonna end up torquing bending the wire. So انت اللي بيريحك والمتعود عليه، عرفت كيف؟ بس بالاخر whatever you put ما راح تيجي تاع البراكت ماجيك براكت مثل ما بيقولوا لك الدايمون انه حط البراكت كل شيء بيمشي. بالاخر you have to individualize every tooth.
اوكي دكتور روي في سؤال خلص دكتور عدلي سوري.
لا بس هيك اخر سؤال. تعتقد دكتور روي انه the use of TADs nowadays change our plans in treatment of missing lateral incisors, especially when you talk about the case is extraction and you extract in the lower arch? In cases when you want to close the spaces, you extracted lower premolars and you close the spaces.
ليك خليني نجاوب انه التادز ما بيساعدوا specifically للميسنج لاترالز. يعني انا ما عم شوف شو زاد التاد للميسنج لاترال. هلا في ناس بيستعملوا تادز اكثر من غيرهم. انت it's a personal preference. في ناس they feel more comfortable with TADs، في ناس بيستعملون. So انت اذا after all missing lateral you're treating a malocclusion. Okay. يعني you're treating a malocclusion whether extraction non-extraction. So if you for maximum retraction for example space closure you are يعني more comfortable by using TAD you use TAD. بس انا ما بلاقي انه التادز فيها شيء specific positive للميسنج lateral cases.
هلا دكتور روي التادز فيها شيء specific بالميزياليزيشن. Now I can mesialize the posterior segments, especially with palatal TADs, without even retracting 1 millimeter of the incisors. So this facilitates for me the exclosure of spaces without any retraction, and this is what I mean.
Okay, sometimes يعني we're talking about very specific cases. يعني انت sometimes إذا for whatever reason قررت بدك تعمل space closure وعندك a lot of space to close. For whatever reason البيشنت ما بده implant Okay, so you might use a TAD to mesial drive those molars. Yes, like you use TADs for any other malocclusion, but it's not really specific for missing laterals.
Thank
Okay.
you. Thanks a lot.
اوكي في عندنا سؤال دكتورة زها عمارين.
Hi Zaha, hey, hello Dr. Roy.
دكتورة
Lovely
زها
lecture.
بتحبي تحكي تسألي السؤال؟
What kind of lateral expansion did you perform for the bridge patient with crossbite? For the bridge patient, you're talking about the first.
Right. Hello.
Hi,
Yes.
hi. كيفك Zaha?
Hi. How are you? Good evening.
Very good. And you?
شو أكيد lecture حلو مثل as always. ميرسي كتير.
تسلمي.
No, I did I say bridge? I meant the bride patient.
Bride patient. Okay. Okay, bride patient.
I don't know if it was a typo.
Thank you, Zaha. It's a good question.
Because you got good expansion.
Yeah, it's a good question. And I started with expansion, knowing that I might not get a lot of expansion. But as you know, in adults, if you don't open the suture, you can still get some bending of the alveolar ridge. So I was hoping to get the best I can, but I got more maybe because of the cleft. But I used the regular Haas appliance, tissue-borne Haas with a jack screw. Okay?
Yeah, thank you.
All right.
عندنا سؤال من دكتور براء. دكتور براء بتحب تسأل السؤال؟ You have the permission to talk.
For space closure, how do you use torque correction to reduce canine eminence? Yeah.
تفضل دكتور براء.
Yes. شوف إجمالاً I just add torque on the wire على الكيناين بس منا كتير هينة to get torque على الكيناين when you put it at the site of the lateral. I agree. بقرب هالشي ليه؟ لأنه the canine is the longest and strongest tooth in the mouth, and you can try to get some torque, but you're not gonna hide the canine eminence 100%. So again, if you have a smile that is normal, showing normal exposure of the clinical crown, you're fine. If you have a gummy smile and a big canine eminence, yes, sometimes it's hard to get perfect torque to hide the canine eminence. But the way I put torque, I usually use TMA wires because they have a lot of elasticity. They don't give a lot of force. لأنه you are putting torque against a central and a premolar. So I don't know if I answered the question, but I usually do it with the wire, with a TMA wire on the canine. Okay?
Thank you كتير دكتور روي. خلصوا الأسئلة. بعرفش دكتور عدلي عندك أي استفسار صديقي؟
لا هلا بزعل مني الدكتور روي، لازم ما نسهره كثير.
مرة أخرى شكرا دكتور
محاضرة
روي.
رائعة
شكرا
جزيلا.
شكرا جزيلا باسمي واسم زملائي في جمعية تقويم الأسنان. شكرا لك مرة ثانية، وبنرحب فيك في أي وقت في بلدك الثاني الأردن.
إيه تسلم، أنا بحسه بلد الثاني. Thank you very much. و anytime you need كمان زوم lecture أو شيء أنا حاضر
حبيبي.
لبين ما نجي نزوركم. Thank you.
يعطيكم العافية زملائي. شكرا جزيلا لحضوركم. أوكي feel free to exit please وتجاوبوا على الأسئلة. يعطيكم العافية. دكتور روي شكرا مرة ثانية.
اوكي
شكرا كثير دكتور روي. باي باي، مع السلامة. ثانك يو كثير.
باي.
نشوفك ان شاء الله. stay safe.
ثانك يو. stay safe.
سلام للجميع. ثانك يو.
هيدا هو. شايفكم هلا. باي.
سي
باي. سلم لي حسابي.
يوصل. باي. شكرا لك. ثانك يو.
اوكي.
ثانك يو فيري ماتش.
باي.
Good night.
Good night.
يعطيكم العافية شباب.
اهلا وسهلا، يعطيك الف عافيه.
الله يعافيك ويسلمكم بالسلامه.
الله يخليك. We will be ending the meeting now. شكرا للجميع، تصبحوا على خير.
من اهلا حبيبي.